Hey everyone, it's Cherry. I just want to spend a little time with you, and make sure you're having a great day, and secondly, to talk about how to treat some of these cardiac emergencies that we're starting to identify when we're interpreting our EKG rhythm. So we've been talking about those atrial rhythms, and a lot of those atrial rhythms are tachycardic, and we've talked about the different rates and how that might affect our patient, but let's talk about the treatments, okay? So first things first, we got a couple decisions to make, like only 3, and they're not hard. So let's look at how we're going to diagnose this to get very quickly to our treatment plan. You're going to find this isn't nearly as hard as you thought. Okay? First thing we have to ask is our patient stable or are they unstable? Now this is not the same as being symptomatic. Okay, you can have a patient that's symptomatic, that's anxious and telling you all these things, but we want to look at the perfusion. Okay, are they perfusing well or not? So some of those things we're going to look at to determine the unstable is, are they hypotensive? So if their blood pressure's in the toilet or headed that way, we know that's going to affect their perfusion, and therefore that makes them unstable. Okay, altered mental status. That is a sign that our brain is not getting the oxygen it needs. It makes them unstable. Okay? If there's other signs of poor perfusion, cyanosis, modeling, those kinds of things that are going to tell us that the perfusion is poor, that will make them unstable. And then the very last thing is chest pain. And the reason we put chest pain in this category is because if we have a cardiac chest pain going on, that's those cardiac cells hollering out at our brain saying, hey, I'm in trouble here, I need some help. And if those cardiac cells don't get the help that they need and they die, that's going to affect our perfusion throughout the whole system. So chest pain, just because of how important the heart is, makes them unstable. Okay, 4 things, easy as pie. Okay, so then once we've determined are they stable or unstable, we've got a rule. Stable patients generally get medicine. Unstable patients generally get electricity. We'll talk about why. So it's real easy. Well, we'll just talk about it now, okay? If I've got an unstable patient, time is of the essence, okay? If they're unstable, their perfusion's poor, and they're likely going to get worse, I need to fix this sooner than later. It is much easier and quicker to put on the defib pads and apply some electricity to this heart than it is to start an IV, spike your bag, flush your line, drop your medication, get your flush, and especially if you've got a patient that's got not much blood pressure, maybe they've got diabetes and their veins are a little tough to stick for whatever reason, that is going to take longer. It just makes common sense that starting an IV and going through all of those steps is going to take longer. Sometimes your patients don't have that extra time. Okay? All right, so next decision we have to make. First one, stable or unstable. Second one, is the rhythm narrow or wide? Okay. Now you know how to do this. You measure the QRS complex, and if it's less than 0.12, or if it's 0.12 or less seconds, then it's narrow. If it's wider than that, we're going to consider it a wide complex, and that'll be more of a ventricular rhythm. Okay? And then the next thing we need to look at here is it regular? Now, guys, this isn't anything new. This is the 5-step approach that we've been looking at rhythms for weeks now. So same thing, we're just going to go through those steps. Is it narrow or wide? Is it regular? And then once we've made that decision, we're going to look at our algorithm that has our treatment plan. Now this is the ACLS algorithm from American Heart Association. This is the latest version to date. They will be coming out with a new one here probably in a few months. But this is the 2015 guidelines from American Heart Association. You can see there's 7 whole steps to this. So this is not hard. Don't make it harder than it is. Let's break it down. Okay, so if I have a narrow complex tachycardia, so we're not going to talk about the wide ones right now, we're talking about narrow complex, and my patient is stable, okay, it's not hypotensive. So if I look in my algorithm, okay, I'm gonna look at the heart rate. Now, typically, heart rates that are less than 150 are not a cardiac event. That's the body trying to compensate for something else, like running, exercising, being scared to death, running a fever, having an infection, bleeding. A ton of different things could cause that heart rate to go up. That is not a cardiac event. It's not originating in the heart muscle, and the rhythm is not the problem. Therefore, if that's not the problem, we're not going to treat it as a cardiac event. But if it's over 150, then we have to start thinking this very well is a cardiac event, and how do we take care of it? Okay? So then the first thing we're going to do once we define that rate, put them on the monitor. If you don't already have them, look at the rhythm, check the blood pressure, check their SpO2. That's going to help us confirm that they are a stable patient. And if they need oxygen, we're going to give it. Oxygen is not a given for chest pain or cardiac events. It used to be. That's old medicine. Now we know that we need to evaluate our patient's need for oxygen. If they need it, absolutely we're going to give it to them. If they don't, absolutely we're not, okay? So right there is in that green box is how we're going to assess this patient. Then, because we've got a little time, they're stable, we're going to start an IV, and we're going to think about giving them, we're not going to think about it, we are going to give them the opportunity to try some vagal maneuvers. Now, the vagus nerve runs from the brain all the way down to our rectum, so to speak, okay? And we can stimulate that vagus nerve. Now, that vagus nerve is the main nerve in the parasympathetic nervous system. The parasympathetic is opposite of the sympathetic. We know the sympathetic nervous system speeds everything up. Therefore, the parasympathetic, it's kind of like the brakes, slows everything down. So if we stimulate that vagus nerve, it will slow the heart rate down. And the easiest way to do that is have your patient bear down like they're trying really hard to have a bowel movement. But if you ask them to do that, they look at you like you just fell off a tree and hit your head. So I find the best way to do that is to pull out a little small syringe, pull the plunger part way out, hand it to them, and ask them to blow hard enough in there to push that plunger out. Now, they're probably not going to be able to, and that's okay. I want them to do that bear down. So think about when you blow real hard in a small balloon or something that's plugged up. You use those pelvic floor, lower abdominal, anal rectal muscles to do that, to help get you more volume with your air. It's crazy sounding, but it works. When we contract those muscles, they get shorter and fatter, and they push on the vagus nerve, and it stimulates it. And it can sometimes drop that heart rate. Now, sometimes that doesn't stay down, and sometimes it doesn't work at all. But if you've got a stable patient, it's worth taking a few seconds to do that, okay? Now, if that doesn't work, then we're going to go to our medications, and we're going to consider a medication called adenosine. Now, adenosine is a naturally formed and present component in our system. So our body recognizes it, and it recognizes that it can absorb it and should absorb it. So if my rhythm is regular, now that's in bold orange print right there for a reason. Okay, if my rhythm is regular, I'm gonna start an IV. I'm gonna give this adenosine. Okay, what the adenosine is going to do is it's going to go in the heart, and it's going to pass through that heart quickly, and it literally chemically depolarizes all of those cardiac cells. Boom, 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 and they're depolarized, which in essence stops the heart. Okay, and it'll leave it stopped for a few seconds, and then almost always the heart restarts in hopefully sometimes in a more organized and slower pattern. Okay, so it just gets a chance to restart, and lets that SA node take charge and keep the rate down where it should be. Okay, now our first dose is 6 milligrams. This is a really rapid IV push because it's absorbed so quickly into the body. We have to get it into the cardiac circulation before it's gone. So I'm going to put my 6 milligram syringe in my IV tubing, and I'm going to put a flush either in the same port or the next port up, and it's like push my drug, push my flush, squeeze my IV bag, and run that in as quickly as I can. Now if it works, you'll see that period of asystole, and then you'll see the heart start back up again. It can be, I don't know, 10, 15, 20, sometimes 30 seconds. It seems like forever when you're looking at that monitor. It's cool when it starts, and then the longer it goes, the more nerve-wracking that gets. But when it starts back up, it's like, yay. If it doesn't work, then nothing happens. The patient doesn't feel anything. It's fine. I always tell my patient, this may feel a little weird, but it'll last only for a short time. Okay? I don't tell them that I'm going to give them a medication that's going to stop their heart, because that's terrifying, and that's not where we're headed with this, okay? So we're going to give that 6 milligrams, rapid IV push, wait for a minute or two. If nothing happens, we're going to repeat that process with double the dosage. So the next dose is 12 milligrams, and we'll go rapid IV push, okay? Now, if that slows the heart down, we're golden. If it doesn't, and they remain stable, we've got a couple options, okay? We can consider a calcium channel blocker or a beta blocker. Both of those will slow the electrical conduction through the cardiac cells, so it makes sense that those would work. There's also a drug that you'll see a lot of times on your protocols called cardizem or diltiazem, and that also works with a lot of patients that don't respond well to adenosine, okay? We could also consider sedating this patient and cardioverting them with electricity. But, you know, if they're stable, I'm going to take them to the ER. I'm not going to put them through that if this is not causing them any danger in their health right now, okay? So it says consider expert consultation, and that's going to be the hospital most of the time, okay? Makes sense. So let's look at the other unstable patient. Oops, right there is our treatment. I have all these little things in here. I forget I put them in here. Okay? So, unstable patients. Now, this is a whole nother ballgame. Okay? If my patient's unstable, again, we're going to look at that rate. We're going to look at the same criteria which makes them stable or unstable. This rate needs to be above 150, or we're not going to treat it as a tachycardic rhythm that's cardiac in nature. Okay, so same thing. We're going to put them on the monitor. We're going to look at the blood pressure, the SpO2. We're going to give them oxygen if they need it, and then we're going to think about synchronized cardioversion, because remember what we said: unstable patients get electricity. Okay, so right over here in our red box, are there any signs of poor perfusion here? We said yes. It's going to push us right over, and boom, right off the bat, the first thing we're going to see is that synchronized cardioversion. Okay, and this is going to happen quickly. If you've got an unstable patient, they don't have a lot of time for us to be dinking around. Okay, now look, there is 2 different voltages for regular and irregular. Okay, so right up there is where we're going to find our doses. Okay, now synchronized cardioversion is kind of cool, but you got to make sure that you do all of the right steps. So we are going to use the defibrillation pads. Okay, and we are going to move quickly with this. Okay, so if we have a narrow regular complex in our unstable patient, then we're going to go 50 to 100 joules. Okay, I personally like to start at 100. I want to do this one time. I want it to work. Okay, if I start at 50 and it doesn't work, well, regardless of where we start, if it doesn't work, the next dose will be doubled, and the next dose from that will be doubled. So if I start at 50, my next dose is 100. In my mind, and this is my opinion only, I think 100 is probably where we should start, because then we don't have to repeat it if that low dose doesn't work. Now, the one rhythm that will respond well to that low dose is a flutter, atrial flutter. So if you can see that flutter pattern, that's where you'll consider the 50 joules. Okay? Now, if it's irregular, please hear me here. If it's irregular, be very, very cautious, because many times that irregular pattern, especially if it's irregularly irregular, is AFib. And AFib, the blood is kind of pooling in those atriums and those little pockets and crevices. And if we hit it with a bunch of electricity or with the adenosine and it depolarizes all those cells, everything contracts and we shoot blood clots everywhere. That is maybe going to be worse than what they're dealing with right here. So be really careful. But if you've got an irregular rhythm that you don't think is AFib, or if you have no other option with this patient, if they're that unstable, then we're going to start that at 120 to 200 joules. Okay? Now, most of our monitors these days are biphasic, meaning the electricity goes from both pads crossways to the other pad. The monophasic machines have pretty much been phased out. Monophasic, they go from one pad to the other. So that does somewhat change how you're going to deliver electricity. Okay, so if you have IV access available, we're going to think about maybe sedating this patient, or if it's narrow complex and regular and we have an IV, we could just consider the adenosine, because it's not going to take any longer if we have an IV already established. Okay, so sick patients get electricity for the most part. Okay. And let me see here if I can make this work. Alrighty, so here's our monitor. Okay, now I'm showing the LifePak 15 because that's what we use in our lab a lot. If you have a different monitor, a Zoll or Philips, you'll need to learn that monitor. But for this one, we're going to look to do synchronized cardioversion. We're going to look for that sync button, and what we need to do, it's going to be right there. What we need to do is push that after we have the defib pads on our patient, and you're going to see the rhythm there tracking right along, and shortly after you hit the sync button, you'll see little triangles start to appear at the top of the QRS. That's telling you that the monitor is recognizing when to give this perfectly timed shock, because we want this electricity to hit the ventricles at exactly the same time that they depolarize. And that's going to depolarize that whole heart in kind of a systematic form and let it restart. Just like the adenosine, only it's going to do it with electricity. Okay. Now, the other thing we have to consider is we've got to set our joules. So right there is our energy select. First dose is going to be 50 to 100 on a regular rhythm. Okay, so we'll set that. Now the little button that you're going to turn to set the joules, once you get it at that desired wattage, if you just push it, it sets it at that rate. Now I can charge up, tell my patient, sir, hang on, this is going to hurt quite a bit, but it'll be over quick. And hit the charge button. Hit the shock button. Okay, again, you're going to clear it like you would if you were defibrillating a patient. Nobody's touching him. It's going to hurt like a son of a gun for your patient. Now, it may not shock immediately. As soon as you hit that shock button, it's going to, remember, it's going to time that. So there may be a little pause before it defibrillates. So don't get too rambunctious and grab a hold of your patient as soon as you hit the shock button. Wait for it to actually deliver that electricity to your patient. Okay? So learn your monitor, learn how that's going to work, and then think about what we've learned. It's less than 20 minutes. We learned everything about treating a narrow complex tachycardia. Make these decisions. Is my patient stable or unstable? Is my complex wide or narrow? Is it regular? I forgot to put that in the conclusion. And do I have an IV available? Once you know that, you've got your algorithm, you know how to treat it. Okay? So I'm going to leave you with these thoughts. Always treat your patient, not your monitor. always. Okay? And never delay synchronized cardioversion on a patient who's unstable. Okay? That's all I got for you. They're simple pearls. I hope they help.